Thanks everyone for coming to this presentation. I'm Dr. Grant Brenner, and I'm going to be talking today about transcranial magnetic stimulation. I've been working with patients to provide TMS since 2010, and our office currently is located in Madison Square Park in New York City. Okay, so a bit about my background. I'm trained in general adult psychiatry at Mount Sinai. In New York, I completed 2 years of general surgery prior to that. And I'm also trained as a psychoanalyst and in various other forms of therapies, including cognitive behavioral therapy, trauma-informed therapy, and other structured approaches. I do a fair amount of disaster mental health work as a board member for Vibrant Emotional Health, responding to various disasters and mass casualty events, and enjoy doing things that are public facing, including a book series on relationships and personal growth, the Irrelationship books, a podcast called Doorknob Comments podcast, and popular blog on Psychology Today, ExperiMentations. Okay. So transcranial magnetic stimulation is a treatment that was FDA cleared in 2008 for major depressive disorder. It's safe and effective. There's few side effects that have been reported, but there are some side effects that generally are favorable compared to medications and are typically confined to the treatment session itself. And so the way TMS works, and we'll get into this in more detail, for depression is that we are stimulating an executive part of the brain called the left dorsolateral prefrontal cortex, which is sometimes referred to as the depression center, but it really covers a lot of different functions, and it's a bit more involved than calling it the depression center, and we'll get into that in a minute. Depression is a very serious problem in the United States. It's estimated that 20 million plus people have depression, less than half of whom are adequately treated. And across the World Health Organization has identified closer to 300 million people now suffer from depression. And again, the majority of whom are not adequately treated. Medications and therapy can be effective, but they often leave a lot of people with residual significant depressive symptoms. And so the data we often look at is the STAR-D trial data. And this was a naturalistic multi-centered study that looked at something similar to what would happen in a clinical practice where people are offered a first medication, then a second one, and various augmentation strategies. What we see from the STAR-D data is that the chance of having a full treatment, a remission of depression with the first medication is about 27.5%. And with each successive medication trial, that goes down to 21, 16, 6.9%. At the same time, with each successive medication trial, the risk of significant side effects goes up until by a fourth antidepressant, over 40% of people are reporting very problematic side effects, which often lead people to stop treatment, switch treatment, or remain undertreated. For example, not going to a higher dose of antidepressant. And so that's really important because what it shows us overall, and this data isn't reported on this slide, but if you pool the data for depression remission with antidepressants, about 36% of people across all medication tries get a full remission of depression. People more likely have a partial response or don't respond adequately. When we look at some of the neuroscience of depression, we see that globally, the brain has less activity for someone who's depressed, as you see on the left, compared to the right, where you can see there's more activity across the cortex. With research and neuroscience, we've identified that one way to affect the whole brain and brain networks described in depression is to target a key area. And we talked about the dorsolateral prefrontal cortex on the left side of the brain as being a key center that's involved with regulation of emotional areas, allocation of attentional resources, and executive function in general. So when we stimulate that area, this is data early on from 2008, we can see that if you stimulate the left dorsolateral prefrontal cortex, you see networked activation through this connection to deeper brain structures. And then more recently, a different group, Zhang et al., studied what is the impact of the standard TMS stimulation on the frontal cortex on various brain networks. So there are three brain networks that have been called the big three. There's many other brain networks that have been described, but those big three brain networks are the central executive network or executive function network, the CEN, the default mode network or resting state network, the DMN, and the salience network, which is what we're paying attention to at any given time. The default mode network is what is running through our minds at any given time. And the central executive network is kind of like the CEO of the brain that manages a lot of different functions. And so in this study, participants received 2 weeks of daily stimulation, and they found even at the 2 week mark, and by comparison, a full standard TMS treatment is 6 to 8 weeks of daily treatments. They found statistically significant activation in the central executive network. And so this is associated with recovery from depression, but it also has a more general positive effect. So for example, though this is not an on-label treatment, a lot of the patients who I've treated with TMS become better able to engage in therapy because their executive function is improved. And I've seen it as a game changer in a number of different patients. It's something that is not in common usage, but I would call TMS-assisted psychotherapy. So when we can boost activity in central executive networks and help with emotion regulation and allocation of attentional resources and management of internal conflict or kind of bottlenecks in processing in the brain, people are able to make better use of developmental experiences, including therapy. That's what I've been observing. Okay. So the less neuroscientifically grounded story is that magnetic pulses cause parts of the brain to fire. And it's like physical therapy for the brain when they're directed at this executive area of the frontal cortex. It's very targeted. So as contrasted with something like electroconvulsive therapy or medication, which has a global effect on the brain and throughout the body in the case of medications, TMS is targeted to the specific area that we want to target and identify. Electroconvulsive therapy, though people think of it with TMS, is completely different. Electroconvulsive therapy causes the brain to have a generalized seizure caused by electrical current being applied to the brain. TMS uses a changing magnetic field, which causes nerve cells only under the magnetic treatment area to actually fire. And so we can really be much more targeted and controlled. I sometimes like to think of it as brain network surgery. If we talk about disconnectivity syndromes as being a problem, the connectivity in the brain isn't right, and that's leading to depression, we can restore good connectivity or eukonnectivity. Okay. And so with standard TMS, and we'll talk about some newer off-label applications where you have the 4 to 6 weeks of sessions that are about 30 minutes per session, Monday through Friday, for a total of 36 sessions, though sometimes we treat people with more sessions. We see a remission rate of 62% and resolution of significant symptoms, at least half a reduction in symptoms in 83% of patients. And if you think back to the STAR-D data, that's much better than the overall medication response, 62% versus 36% max. And in some more recent studies, the first study that compared TMS with polypharmacy with multiple medication trials found that standard TMS was much better than 2 or more medications, even in the presence of psychotherapy. They did a direct comparison. So TMS until recently has been approved in adults, but there's been interest because of the epidemic of teen depression and other problems. And so recently NeuroStar TMS has been approved as a first-line treatment for depression in people 15 years and up. So whereas with adult TMS, people usually will try medications first, at least for the on-label use, though many people will ask, can I do TMS instead of medication? With teens, the data was strong enough from a large review of outcomes to get an indication to offer TMS instead of medications to people 15 years and up. And so if we look at the CDC data, and also I think most of us are aware of this, there's really an epidemic of depression among teenagers and young adults. And this is reflected in the CDC data that's tracked up until 2023, where although we've seen some improvements, the rates, for example, of persistent feelings of sadness or hopelessness in 2023 affected 40% of teenagers. Those reporting poor mental health, like almost a third, and a fifth seriously considering attempting suicide, and almost as many making a suicide plan. And so there really is a great unmet need. And in teenagers, medications can be more complicated, though helpful in many ways because they can interfere with social function or weight and affecting things like appearance or affiliation with other kids. So medications have a lot more side effects, whereas TMS can be an alternative that is much cleaner for them in terms of side effects. And if it works, that's really good because it has helped and they have minimal residual side effects, if any. And if it doesn't work, you can still, as with adults, try more intensive treatments with medications. And so in adolescents, with the standard protocol, we see close to a 50% remission rate, which is much better than medication. And we see nearly an 80% improvement, at least in half of symptoms, which is also very significantly correlated with improvement in function and well-being. So we'd rather see a 50% reduction in symptoms with minimal side effects. And so NeuroStar has been used with a large number of adolescents already, over 10,000 treatment sessions or patients, I believe, since it has been used. Okay. People will always ask, how long does TMS last? The data on this is not well understood. I've treated patients with TMS who never required retreatment with TMS. And even years out, it really changed the direction of things. A percentage of patients will need either a booster treatment if they start to feel more depression following the initial course of TMS, and we monitor closely afterward. So we can catch people early and work closely with therapists as well to identify signs of early recurrence of depression. Most people who are retreated respond well to it. There's a small percentage of people for whom it doesn't work again. And some people we find will benefit from having some regular TMS treatment, some number of sessions a month, usually a few sessions a month, 1 or 2 a week, in order to maintain the response. And that's determined on a case-by-case basis. Essentially, we, try to find the minimum amount of maintenance treatment that maintains a good response for those folks. And overall, that seems to be a safe strategy. TMS does not appear to have any kind of long-term negative effect, and so people can safely receive maintenance treatment. Okay, moving on to obsessive-compulsive disorder. There's interest in using TMS for a number of different conditions. OCD has been a condition which has received FDA clearance, and the NeuroStar system, which is the system that I use, has a treatment protocol that's effective for OCD. The first-line treatment for OCD remains medications and therapy, but OCD is a kind of a chronic condition which affects function so significantly that it's really important to try multiple different things. And as with depression, and perhaps even more so in some ways, if you can achieve a 30 or 40% reduction in symptoms as reflected in something like the Y-box, the Yale-Brown Obsessive-Compulsive score, it's really associated with greatly increased function. And so patients may not only get time back during the day where they're not engaging in compulsions, when they are doing other things, if their obsessional load is significantly decreased, they're much more able to focus on things and get other things done. So if you think back to those 3 brain networks, OCD helps to strengthen the ability to not get bogged down in obsessional thinking And so the default mode network is not filled up with all these obsessions, which opens up bandwidth to think about other stuff. And when people are trying to focus on something at work, their salience network is stronger and they're able to direct what they're focusing on to meet the needs of the present moment rather than getting pulled into obsessions. That would be one way to think about it. With OCD, from a neuroscience point of view, there's something called the CSTC loop, the cortical striatothalamo cortical loop. And so with OCD, there's a way where the brain circuit is going through a recurrent loop, sort of like a cardiac arrhythmia, from the cortex to the striatum, which is the sort of habit and reward part of the brain, to the thalamus, which is kind of like the switchboard, and back up to the cortex. And TMS and other treatments that treat OCD reduce the intensity of that looping effect. And researchers are still working to understand what are the different patterns of brain network activity in OCD to determine specific targets that may help different subtypes of OCD. Likewise, with other conditions that aren't on label for TMS, like post-traumatic stress disorder, ADHD, and other forms of mental illness, if we can identify the brain circuits and the targets, we can get treatment. And so there's been very interesting work on that recently, specifically for PTSD in personalizing targets. Okay. So summing things up a little bit, TMS is safe and effective. There's few side effects. There is some kind of tapping sensation during the treatment. Some patients experience discomfort. A small subset of patients experience pain. There can be nausea sometimes afterward. Sometimes people have some neck tension or headache afterward that generally resolves. There's a very small risk of a seizure, which does not lead to an ongoing seizure disorder. A typical treatment session, patients come in, they sit down in a comfortable chair that reclines. The magnetic coil is placed over the scalp. Once they get settled into the treatment after the initial planning sessions, it becomes very straightforward and routine. They come in, there's no sedation or anesthesia required, there's no recovery period. They come in, they get treated, they talk with our technician, our TMS coordinator, and then they can just go back to whatever they were doing without any kind of need for recovery, as contrasted with things like ECT, where people who will get sedation and anesthesia and often have memory problems. TMS doesn't cause any cognitive clouding and, in fact, often improves cognition. Okay, so finishing TMS is really key. We really work with patients to make sure that they get to complete it. The standard TMS treatment being 5 days a week is a commitment, but quite doable, Monday through Friday, and we can be flexible. Now, there are some newer applications for TMS that are important to talk about, but are not FDA cleared yet with most systems. There is a form of accelerated TMS that is cleared with something called Saint TMS. And so other TMS providers want to get this kind of benefit. And so we have developed accelerated TMS protocols which use a more compressed treatment. And so the full course of TMS can be administered within a 5-day period. Patients receive several sessions a day, and rather than a 30-minute session, we use a more potent type of TMS stimulation called intermittent theta burst stimulation. And that's about 3.5 minutes long. And so that can be done 6 to 8 times a day. And what we found in pilot studies is that the remission rate after a period of weeks after the initial treatment course can be 70%, and in some samples higher. And people often respond rapidly within the first day or two and experience a quick decline in depression symptoms. So you can see how steep the improvement goes down. And as with standard TMS, we monitor closely and will retreat if necessary or provide maintenance treatment. And so this has been really amazing. We've treated a number of patients with this off-label accelerated protocol now, and have found it to be very helpful. And the same type of effect, we've often seen that patients who receive accelerated treatment will be able to engage in therapy much more effectively as well. Okay. And this has been used predominantly for major depressive disorder, though we wonder whether we can use theta burst with other types of conditions, because with the theta burst, just to be a little bit techie for a minute, instead of giving single pulses like 20 a second, it gives bursts of pulses that have many smaller pulses superimposed over the main frequency. And that allows us to deliver more magnetic pulses and more, therefore, firing of nerve cells in the brain in a very short period of time. And so a patient will typically come in and get one session every hour, and they're able to spend time here, do work in between, relax, go out. Madison Square Park is very nice, get a bite to eat for lunch. And the determinants of outcome seem to be not just the number of pulses and the number of sessions, but also data shows that if people get TMS in a shorter span of time, it's also more effective. One of the questions is whether targeting needs to be done with something like an MRI. And right now, it doesn't seem like it's very clear that we need to use neuronavigation for targeting. More is to understand when would neuronavigating using like an MRI instead of standard measurement-based approaches be useful. And as I said, that's an open question. And the most important determinants that have been identified now are the number of sessions and the shorter period of time that they're given in. In the future, we expect and want to see personalized TMS protocols. Okay. And so for on-label FDA-cleared TMS protocols for depression, coverage is very good. Most major insurance plans and many of the public insurances now, Medicaid in many states and Medicare across the boards, can cover TMS. And so if patients have out-of-network coverage, we will work to get those cases approved. And for us in particular, in my practice, we're in the process of getting credentialed with major payers. And so generally speaking, TMS is very well covered. It's a treatment which should be considered for patients with treatment-resistant depression who are failing to respond to a couple of medications and therapy. And I'd say the sooner the better for patients to help get them out of the depression, and working with patients to help them access the treatment and follow through is part of what TMS practice will do in collaboration with referrers and patients.
My name is Johada. I'm the wife of a gorgeous husband. I'm a mom with an 11-year-old brilliant son. My husband helped me to find NeuroStar. There was so much care in the way that they treated me. In the consultation, when you learn that it's non-invasive, it relieves what is expected of you. All you have to do is give it a chance. It was always asked, what about this? Does this feel good? Are you okay? The continuous questions caring for me was so obvious that I never felt uncomfortable. I guess I trusted them. My NeuroStar experience began with me in one aspect, and it ended at a different point in my life where now I can enjoy my family.
Okay, so I'll respond to questions in the chat and have time for Q&A in a moment. So it's a very safe and effective treatment. Many thousands of treatments have been provided to people. There have been minimal side effects. And this very rare risk of seizure is less than a 0.1% chance per patient, which is a single event. It doesn't lead, again, to a seizure disorder. We're very careful. Most patients can receive TMS. There are a few contraindications. One of them is having a significant amount of metallic objects in the head, whether they're sort of static, like certain types of clips or implants, or plates after head surgery. in some cases, or whether it's something like an implanted stimulation device in the brain, which would be a contraindication to TMS. Aside from that, it's generally safe and effective for most patients. There's even some data that people with pacemakers, as long as none of the pacemaker equipment for their heart is really above the collarbone, that's also been shown to be safe. So that can be very helpful for people with certain types of medical problems. Okay, so thank you for listening to the presentation. There are some resources here for our website, or to ask for a referral, or to learn more about me. And people can visit NeuroStar's site as well for referrals closer to where you live if you're not in the New York area. Though we're happy to have people come in, and especially with the new off-label accelerated protocols, it's possible to stay in New York for a week and receive treatment.